Good afternoon, everyone. My name is Adam Del Molino, and I'm the Senior Director of Virtual Care and Clinical Affairs at the Massachusetts Health and Hospital Association. I want to welcome you to today's webinar, Aging Service Access Points, or ASAPs, and Hospital-to-Home programs. A few logistics before we start. If you have questions during the webinar, please enter them into the chat feature as we are in listen-only mode. The questions will come directly to us, and we will do our best to address as many as we can at the end of the presentation. I also want to take a moment now to thank MHA's 2024 annual sponsors and strategic partners for their support in underwriting today's webinar, which is just one of many events that we offer throughout the year to connect our members with leading experts to help address timely issues, including hospital partnerships with our local aging services access points and area agencies on aging. I'm pleased to introduce our speakers today, Betsy Crimmins, Executive Director of Mass Aging Access, formerly Mass Home Care, and Lisa Felsi-Jimenez, Director of Nursing and Transitional Care at Mystic Valley Elder Services. Betsy Crimmins, JD, is the Executive Director of Mass Aging Access, the membership association for the 27 Aging Services Access Points, or ASAPs, and Area Agencies on Aging, also known as AAAs, across Massachusetts. This single statewide network of coordinated care delivers home and community-based services to over 60,000 older adults monthly. Prior to this position, Betsy had the privilege of working with disabled individuals and older adults in underserved communities for many years as an elder law attorney at Greater Boston Legal Services. Betsy has expertise in affordable housing, homelessness prevention, healthcare programs, including Medicaid, Medicare, dual special needs plans, and home and community-based services. Lisa Felsi-Jimenez, LSW RN, is the Director of Nursing and Transitional Care at Mystic Valley Elder Services. She started her work at Mystic Valley in 2004 when she was hired as a care manager. Through the support and mentorship of staff within the agency, she was promoted internally to multiple positions where she was able to develop skills within all aspects of the home care model. Thank you both so much for being here today, as we are looking forward to this discussion. I will now hand it over to Lisa to get us started.
Thank you so much, Adam, for that awesome introduction. I'm so excited to be here today to talk about our hospital-to-home partnership with Betsy. And in the ASAP world, Betsy is she's a legend, and she's unbelievable. So I'm just so honored to be speaking with her. Thank you so much. So today I'm here to talk about our hospital-to-home partnership and the successes and lessons that we've learned in working with our local hospitals. And just another introduction, Betsy and I, and our contact information. I've had an update in my role, so I'm clinical services now, but we're going to start the presentation focusing on our goals. We want to do an overview of the hospital-to-home collaboration between ASAP's Aging Service Access Points and hospital systems. We're going to provide information regarding our liaisons works with Tufts and Cambridge Health Alliance. We're going to review a case study of a patient who's enrolled in our program, inform you of new exciting partnerships that we have going next month. We're so excited. And we're just going to do a quick overview about Aging Service Access Points, including core services that we provide. So thank you for being here with us today. I hope this is really informative and helpful, and we're so proud to tell you about the work we do through the Hospital-to-Home Partnership Program. So our Hospital-to-Home Partnership Program, just to give you all an idea of who we're working with, so it's a partnership between Mystic Valley Elder Services, AgeSpan Elder Services, and Somerville Cambridge Elder Services, collaborating with the Tufts Medicine and Cambridge Health Alliance hospital systems. So the first program we're going to talk about is our partnership with Tufts Medicine. So this program was issued by the Mass Executive Office of Health and Human Services. The goal was to support collaborations between aging service access points and hospitals to reduce unnecessary discharge to nursing homes. So our task was to embed our staff at Mystic Valley, AgeSpan, and Somerville Cambridge in hospitals to help facilitate transitions for older adults back to the community. In this partnership, AgeSpan is our partner, and we lead the initiative at Mystic Valley Elder Services. And we work with Tufts Medicine at the Melrose, Wakefield, and Lowell General campuses that include Saints Memorial. So Mystic Valley's liaison goes over to Melrose, Wakefield, and AgeSpan's liaison covers Lowell General and Saints Memorial. And that's because those are our demographic service areas. So we want our liaison stationed in our hospital that can transition appropriate, discharges directly to our service area and vice versa from AgeSpan. This partnership program has assisted over 480 patients and their families since the start of our program in July 2023. I'm so excited and proud to tell you that information. Our program provides opportunities that create a meaningful impact on reducing rates of readmission to hospitals while diverting patients from nursing facility level of care to support them in the community at that crucial point of discharge. Our plan was to leverage our collective resources and expertise to work with these patients because we understand that the hospital has an expertise about what's happening with them prior to discharge, and we have the expertise when they get into the community. So if we were able to work together prior to that point of discharge, we felt that we could make such a successful intervention and support them from the minute they return home, get them to their follow-up doctor's appointment, and make sure that they are warmly transferred back into the community. The referral process, it's interesting. So our hospital to home liaison is an embedded member in the hospital care management team. She's receiving referrals directly from social work and nurse case management staff in person, via email, or through their messaging HIPAA safe platform, Tiger Text, which has been such a benefit to us. We don't have that in the ASAP world, but I'm hoping we will at some point because it's so wonderful to be able to connect with hospital staff immediately back and forth and just go back and forth about what's going on with the patient, a room we should be in. So it's really a benefit to us to have access to all of their systems. And Tufts has been so gracious in providing us all access to their systems and training us on how to use their systems. So we really feel like we are now skilled in communicating with hospital staff. We review Epic daily. We look at the census with a goal to connect to patients where meaningful engagement will be. Most of the patients we're engaging with are over 60. That does not mean that we will not take a referral under 60. We will take any referral that's provided to us by the hospital staff because our goal is to support hospital staff, connecting their patients to resources. If we're not the right resource, then we want to get them to the right resource, and we will help hospital staff do that. It's our main goal. We also want to be in communication with the staff about in-home services in real time. That's our goal. So we often heard that we received a referral, but we're really wondering what has happened once this person is ready to go to the community. And now because we're able to access Tiger Text, we're able to let the hospital know, you know what? Mrs. Smith is going home and services are going to start, and immediately text them, and they're going to know that message and feel that they can send their patient home, and we've taken over and they're going to be in our hands. Building rapport from the bedside. So we're going to meet directly with the patients when we get this referral in their inpatient setting to build rapport and assess their needs to start service planning. We're going to review their current supports and conference with the care management team to begin the process of referrals for community services. And we're going to support the patient in providing options for additional programs that may benefit their transition to the community. What we have noticed in doing this program is that patients are incredibly critically ill when they're in the hospital. People are not admitted for minor reasons, it appears to us. So when we go to the bedside, they might not be willing to have that conversation with us, or they might be too ill. So we're going to go in there, leave our information, and we continue to try and go back every day while they're admitted, try to get into their room to see if they're progressing, if they're feeling better. And then at that point, in day 1, they might not be willing to talk to us, but by day 3, when they're kind of feeling better, they might be able to say, okay, now I'm interested in this. Or, you know what, I'm not ready, but could you call my daughter? Here's her information. Because we really don't want to be, in there and interrupting at this critical sickness point, but we want to make sure that we make that rapport directly in the hospital because it means so much rather than just getting a cold call when someone's discharged. Knowing the person's face and knowing they're going to come to your home and see you have been really crucial steps in us building relationships with these patients. Our goal is to bridge the gaps of care and communication for the hospital staff at Tufts. We understand they are so busy. The hospital staff are under so much pressure right now. There's high, there's a high amount of patients in the bed. They're trying to get people out. They're working with insurance and families, dealing with all these social, emotional, medical issues. We want to make sure that on our end, we're not trying to make them call and make referrals, or they're not trying to figure out who is associated with one of our consumers when they're already enrolled in our programs. So our liaison is acting as the person who is assisting communication between the aging service access point staff and existing consumers. So any patients that are enrolled in any of our home care or SCO programs that are already in the hospital, our liaison will look in our internal system, connect them to the hospital staff, and make sure that they understand this person is assigned to your patient. These are the services that they have in the community. Would you let us know when these services are ready to be resumed? And so it makes it really easier for the hospital staff. They don't need to cold call an ASAP anymore to try and leave a voicemail and figure out who's working with their patient. We also review our schedules during meetings with the hospital staff. So they might say, I'm sending this patient home. I need to know when their, cleaning services, when their personal care services. We're able to look right in our aging and disability system and give them up-to-date schedules and information about emergency contacts that they might not have, or information about the home environment based on our last assessment. Because we're bringing our laptops right to the hospital, we're able to look in our systems and provide them that valuable information that they would not have had unless we're there present in the hospital working with them. And again, our real goal, we're trying to save the hospital staff crucial time and energy. There's enough that they need to do while they're at the hospital, and we want to do that internal coordination. The hospital to home liaison is going to visit the patient in the community setting post-discharge to assess needs and environment. We want to ensure the service plan is being received and scheduled that we've developed. And I want you to know that I feel like this is where we do our magical best work as ASAP staff, because that is our focus, is community services and assessment of the home. So as we're looking at the home, we're figuring out what's going on, what's the real picture, what was I told in the hospital that I'm not really getting from the patient at the bedside, and I come to the home and I see, wow, things are really not as they seem as the patient's telling their medical staff. There's lack of food, it's cold, there's lack of supplies, there's things that we don't really get the truth about because of fear or embarrassment or wanting to leave and get home. And so that we're able to put that picture together and follow up with the hospital staff, it's really important. Next time they know if this person comes back in, there are a lot of needs that aren't being met that we're trying to meet in the community. While we're at the visit, we're going to review that the patient has access to all their medications as ordered at discharge, that they understand them. It's like a light Coleman model from the University of Utah, where we do those pillars, but it is not a real med reconciliation. We leave that to the visiting nurses because our hospital to home liaison staff are not clinically trained. They're supervised by me, but they're not nurses. But we want to make sure that the patient has the medicine and that they understand why they're taking it. And if not, then we'd follow up with the doctor's office or the VNA while we're there and make sure that we get that reconciled. Call the pharmacy, figure out how we get the meds to the house. We also are going to make sure they have that transportation to the doctor's appointment secured. That is so important, getting back to the doctor's office after that initial discharge from the hospital. And we want to make sure if they don't have transportation, that's what we're doing. We're accessing transportation, setting up their rides. We follow them until the transition is secure and that they have a supportive community agency established. That might be Mystic Valley Elder Services. It could be Age Span. It could be that we're referring them out to a one care program or mass rehab or wherever they're going based on their age and their demographic and what programs they meet. We're going to make sure that they have a secure, supportive agency established prior to transferring them and transitioning them out of our program. We update our hospital staff. We let them know the patient, we saw the patient in the community. If there's anything that we need to follow up back with them, we'll let them know. But we've, realized that most of the time, once these patients leave their hospital, the hospital is trusting in us that we're going to do the follow-up. And most of the time they're, moving on to their next patient because they're just so busy at the hospital. So that was our Tufts Medicine with Age Span and Mystic Valley Elder Services. And now I'm going to focus on our hospital to home partnership program with Cambridge Health Alliance. So this program was issued by the Massachusetts Executive Office of Health and Human Services. The purpose was the same when we applied. The funding was to support collaborations between Mystic Valley, Somerville, Cambridge, and the Cambridge Health Alliance hospitals at both Cambridge Hospital and Everett, the old Whidden Hospital, Everett Hospital. We embedded our staff in both the hospitals to facilitate transitions back home. Somerville Cambridge leads this initiative, and we're the partner, and we are working with both those hospitals at Cambridge and Everett. This partnership has supported over 460 patients and families since the start of our program in December 2023. So we're coming on to its birthday, but we're so excited. 460 patients seems like a really great number for us. We meet bi-weekly as a team, Mystic Valley and Somerville Cambridge. We discuss cases, we evaluate workflows, and we collaborate on processes, procedures, how we can do a better job to support the hospitals and the patients. We accept cases from Cambridge Hospital that discharge to our service area, and we work with the hospital to home liaison that's stationed directly in the Cambridge Hospital, which I think is kind of interesting that we're facilitating, discharges directly from Cambridge Hospital. Even though we're not in that hospital, we're collaborating with the liaison so that there's going to be a seamless transition into our service area. If someone's going to Everett, Chelsea, Winthrop, Medford, Malden, we're going to take them if they're at Cambridge Hospital. In this program, our hospital to home liaison is embedded. She is truly a member of the hospital to home staff. The hospitals are run differently, and so we've tried to adapt and make our programs work, for our hospital staff. So they're telling us what they need, and we're going to meet the need. So when we started this program, Cambridge Health Alliance said, you know what, we'd really love to have you in our daily rounds. So we're there every day at Everett Hospital, and we're an integrated member of the CHA care management team. So our hospital to home liaison receives referrals directly from social work and nurse case management staff in person during rounds and electronically via the in-basket in Epic. Whereas at Melrose Wakefield, we're not really using the in-basket. Everything is more read-only at the Tufts hospitals. At CHA, we're documenting directly in their medical record system, which adds a different level of responsibility for us. We take it seriously, documenting in someone's medical record, but also it helps the CHA staff because there's not like a tiger text method at CHA. So while we're communicating, it's mostly going back and forth through in-baskets through Epic. And it's just the way that their hospital manages. It's just a different system. So we've said, let us know what works best for you, and we're going to make it work for us. Our hospital to home liaison reviews notes, able to look at the discharge process, able to see if things have changed since we've already planned something, and we adapt our plan. And we're also able to document our entire home visit in the Epic system after the patient is discharged. And then the care team, including the CHA primary care members, are able to see what happened and what we saw at the home visit, which I find fascinating because, you really don't know what's going on in someone's home when someone's at the doctor's or at the hospital, so that we're able to document that right back in their electronic medical record and say, we got there and there was really a big need for, toiletries, and there was no soap in the bathroom, and just things that you wouldn't really think of. But when someone has a wound, or when someone has, someone comes into the hospital and they've got, issues with hygiene. Oh, I understand now. The hospital to home liaison saw them at the house, and they realized that there's a struggle there. They might be, there might be places where we're missing things when the person's in the hospital. So we're so thrilled that we can report that back in our documentation to the hospital system. Culturally competent care is major for us at CHA. At all of our hospitals it is, but our liaison at the Everett Hospital is serving the needs of our Haitian population by assisting with Haitian Creole translation. She speaks Haitian Creole, and so she's working there to support both our CHA Everett consumers and our CHA Cambridge consumers when there's a language need. So she will go over, or she will jump on a call or a Teams and figure out how she can help the person who's in Cambridge who does not speak Haitian Creole translate, because it's so often important. Sometimes we will just take those cases as well if we need to, because it makes sense to connect them to someone that they feel comfortable with culturally, they can understand their needs and understands the language. And so we've really found that that has been such an excellent collaboration for us. The patients feel so supported when they're met with that culturally competent care. And we have all of our information about our program translated into the top 5 languages in our service area, which are Russian, Haitian, Spanish, Vietnamese, and simplified Chinese. So all of our information is translated into that, so that if someone comes in, we're able to bring that information to them at bedside and they understand, okay, this is what's going on with this person here. Because oftentimes we may be reaching out to the daughter or the son or someone to translate if there's no one available. But we've noticed, as everyone does in healthcare, that when you're communicating back and forth with the patient directly rather than going through a translator, it's just making such a difference. So that has been so important to us in the hospital to home program. So we are meeting directly with patients at the Everett Hospital. We review their current supports and conference with their care management team during rounds. So they're right there in the morning with them every day during rounds. So in the morning on a Monday, we might get completely different information, or on a Tuesday than we're going to get on a Thursday. We thought the daughter was available, but now we have different plans. The daughter's not going to be a caregiver. We need to have additional supports prior to discharge. Then we can adapt our plan and make changes and figure out a way to make the program work and make the discharge plan adapt to meet the needs of the patient when they leave. It's so nice to hear in real time what's happening. We might think someone's ready to leave on Friday, but something happens. They have a change in their medical status, and now they need to be over on the weekend. We can update our vendors and let them know she's not coming home on Friday. Let's reschedule those services to Monday. So being in rounds is making a huge difference for us in letting, updating our internal ASAP team, and also getting, providing information of what's going on in the community for service planning to the hospital staff. We're meeting with the patients at the bedside again, but sometimes, we're going back a couple times if they're not ready to meet with us the first time. We're very determined we're going to get you in our program. In this program, which I think is awesome and very interesting, and I know when we meet with Cambridge Health Alliance, they have such a robust geri psych floor at CHA in Everett. They have a lot of older patients on the geri psych floor that do not have connections to the community, who have mental health, behavioral health, social determinant of health needs that we need to meet. So we're going right up to the geri psych floor when we get one of those referrals. We're able to meet with the patient if it's appropriate. If they're not willing to meet with us, we're meeting with the caregiver, the hospital staff, and then we help plan a transition to the community. And sometimes that'll include bringing in an adult day health, so that we know that during the day that they're going to be, getting their skilled nursing at the adult day health, or they're getting, their vital sign checks, or we're bringing in a caregiver support program so that the caregiver feels supported as this person transitions to the community, and we bring in a more robust service plan. So we're really adapting our services based on what the needs are, and bringing in all of our ASAP specialties directly to these patients before they even leave the hospital floor. And that's just why I just love this program. I'm so passionate about it. I just think it's so important to do this work. These things would never have connected if we weren't directly embedded in the hospital. And I just cannot speak to the value of that enough for this program. So right now, I'm going to go over a case study of a patient who was at Tufts Melrose Wakefield Hospital. This is a true case study. So just give you an idea of a patient that we're working with and how we've done this work, okay? And this is kind of, some of the patients that if we did not have the hospital to home program, we would never catch and never see. And then, who knows, right? So we worked with a patient who was a 61-year-old divorced male who was referred to our program in March 2024. He was homeless and living in the Revere Malden areas in his truck. He was admitted to Melrose Wakefield Hospital for 4 nights with a diagnosis of hypertension and ketoacidosis because he was unable to manage his diabetes. He couldn't afford his insulin. He'd been working in construction, but he was laid off and was unable to afford his rent. And he faced an at-fault eviction, and he'd been in his car for a few weeks since eviction, but he could not manage his own health. His legs were so oops, I'm sorry. His legs were so edematous from the pressure of sitting upright and not being able to rest in the lying position in his car. This was the saddest part to us. He was literally like really unable because he had all of his, most important items from his home in his car. And so he was just sitting upright in his car with these super edematous legs. So, I'm sorry. Let me go back. Okay. So the barrier to his cares and his goals. So he was first unable to navigate the insurance system and he needed counseling regarding his benefits. His goals were to contact the unemployment office as he had not received any funding since the time of his layoff and to look for housing opportunities in the area. He had limited support from his sister who lives out of state, and it wasn't an option to stay at her home. We were told, the relationship was pretty rocky and she was kind of just for emergencies, and that was not an option. So we had to figure out how we were going to help him down here. So his barriers to care included homelessness, unemployment, chronic health conditions, his inability to afford medications, lack of informal support, his food insecurity, his inability to manage his diabetic diet due to the cost and lack of access to appropriate food. So we had our challenges up against us, but we said, you know what, we're going to help this consumer, this patient, we're going to get him to a place where he's more stable. So we scheduled an in-person meeting at discharge at Mystic Valley Elder Services because we obviously couldn't meet him at his home. He's living in his car. He visited our agency and discussed critical issues that had to be addressed first to ensure that he manages diabetes. First thing, he came in and we said, we got to figure out how you're going to get access to unemployment, locate your insurance information on the electronic verification system through Mass Health. We were able to call CVS. We expedited his meds. And we had no money for gas or meds, so we applied for funding to get a gas card and all the co-payments for his medications. Then we gathered all food and toiletries from our emergency pantry that we have internally at Mystic Valley. So when he came here, we got a big bag of all the stuff he needed, and we gave it to him. And so we knew he'd have access to food and medications in his car. We then adapted our care plans to figure out what we were going to do. We said, we got to think outside the box. How are we going to help this man? He needs help with bathing and dressing, and he has no access to a shower or a bathroom. So we all talked, my team, my hospital toll liaison, my manager, Katie, who's a LICSW, and myself, and we always problem solve these cases. And we said, what if we applied to the Malden YMCA? Not only could he go shower, he could also go exercise, walk on the treadmill, get his legs moving, get himself moving, and then he could make some friends while he's there. We know there's a lot of seniors in our area and aging, older adults that go to the Y every day. Maybe he'll meet like a group of guys there and he'll feel comfortable, and want to go back. So after 30 days, we had him open. We ended up getting him to the Y. He started walking every day. We closed him out of hospital to home, and we opened him to one of our other programs through the Executive Office of Elder Affairs, the Anchor program, so that we could provide him additional intensive care management and support. So that's the important thing with these programs. We're not just going to close you out and not have some place for you. We're going to transition you so that you're connected in case, God forbid, you need to go back to the hospital. And then you're going to have another connection, and you're going to feel comfortable at discharge next time that there's someone looking out for you and able to put in your services. So, progress post-discharge. So our patient is managing his diabetes. He's attending medical appointments for follow-up. We've done a ton of housing applications, and we're in the process of gathering supporting information. Unfortunately, he is still sleeping in his car. I wish I had an opportunity to tell you that he did not sleep in his car. He's still in his car. He's started to utilize the Malden warming shelter overnight due to the cold weather, where he does have a group of friends that he talks to when he has friends at the Y. He's going to physical therapy, and his back pain is more manageable because he's got the support from therapists, and he's continuing to work on his exercises when he goes to the Y, and he gets showered and he walks. But unfortunately, the housing thing is still a major barrier for him, but he's continuing to work with us, and we will, we're not going to let him fall through the cracks, and we're going to continue to follow up and make sure that when he gets that housing interview, we're there with him and present, and hopefully we'll be able to support him in applying for first and last month's rent through RAFT. So I just love to quickly talk about our successes through the hospital to home program. I think that case study is definitely a success, and it highlights the great work we do. And also it highlights that, You don't need to have a home to be in hospital to home, because we know that right now there's so many homeless elders and homeless disabled adults in our service areas. And so we don't want to not connect them to our appropriate programs. We want to make sure that no matter where they are, we can meet them where they're at. Patients who are ready for discharge, who are enrolled of services prior to an intake assessment, are open to our home care services programs via presumptive eligibility. And what that means is that we're able to utilize our internal programs through the Executive Office of Elder Affairs and open them to home care before they have an assessment. So we put in services and then we work backwards and go out and determine their eligibility. And that's really helpful. We don't have to wait, schedule an intake assessment, wait for someone to go out there. We're enrolling them while they're at the hospital, which is excellent. We're also swiftly expediting the home care process by getting our patients in touch with a vendor so they can get their services started right when they leave. And if we were waiting for them to go through the entire intake process, it could be a week to 2 weeks to 3 weeks before this starts, but we're doing this right before they leave the hospital and then working backwards. So I just really think the connection to the vendor and having them come out date of discharge is really a great, like a revolutionary way that we're putting in services. And then patients have access to care at the time of their discharge instead of waiting, which is diverting them from nursing facility placement. We're also successful at collaborating as a team. We're training as a team. So our Mystic Valley's team and our age span team for the hospital to home liaison program, we're trained together. And we have a quarterly meeting and a lunch at Mystic Valley or Age Span where we work together and we talk about best practices, what we need to do to modify, adapt, what things have worked and what things don't work. The trainings we did together, which we thought was actually, it was just so fun to get to know the other staff at ASAPs and kind of know what they're doing. But we did motivational interviewing. We did overviews of both of our agencies, so I understand what's happening at their agency. They understand what's happening in ours, because not all agencies are the same, even though we provide, a core group of programs, but things are a little different. It's interesting to learn and then adapt your practices. Health literacy was a huge one. We did a program with the Mass Rehab Commission, which is now Mass Ability. We did a program on all the waivers that Massachusetts offers via Mass Health. Options counseling. We did a big program on community safety. And then my favorite, other than hand washing, is chronic diseases. So we did a big chronic diseases where we talked about all chronic diseases, basic chronic disease information. So our care managers, including like the hospital to home liaison staff, understand what is going on with a patient who has hypertension, who has diabetes. And then we can service plan basing our care planning on their ADL needs, which we find so important for these patients leaving the hospital. A big, awesome benefit of this program has been working with the Community Transitions Liaison Program. As we know, the Community Transitions Liaison Program started in July 2023 through the Mass Office of Elder Affairs, and this program works to embed a nursing facility transition liaison person that's in every one of the nursing facilities in our state that are DPH funded and Mass Health funded. And the hospital to home liaisons are working with those community transition liaisons with a goal of discharging patients home who may not have been able to go home from the hospital. So as we know, we need nursing homes no matter what. Not everyone is going to go directly from the hospital to home. There's people who need daily skilled nursing, intensive PT, OT, medication management, and skilled services that we're not going to be able to provide immediately upon discharge. And therefore, we are going to use our hospital to home liaison to connect them to our community transition liaisons who are in the nursing facilities. They will see the patients at admission to the nursing facility, and then they will provide support for the discharge. So it goes hospital to home, then to the nursing home, and the community transition liaison program takes over. And there's a seamless transition, and we're not dropping patients. We're like cradling them and moving them on in our hands as they go from program to program. I'm so proud of it. The Community Transitions Liaison Program is my passion. I love it, just like hospital to home. And so getting people out of nursing facilities, we're working on it, but they might not be ready at time of discharge, and we don't want to let them lose hope. We're going to help them get out as soon as we can, if it's appropriate, via this program. Also, I think a huge success is our support for hospital staff. I think we've saved them a ton of time and effort through this program. We've communicated, we're streamlining, and connections have been made. And we're able to resume services without delay. So that's been excellent. Also, our social determinant of health screening has been really successful. Our hospital to home liaisons are doing a social determinant of health screening at the initial home visit. We upload it into our aging and disability system, which is SAMS, through the Executive Office of Elder Affairs, through our ASAP program. And so we are able to address interventions by hospital to home liaisons, referrals to outside providers, assistance with SNAP benefits, mass health applications. We explore housing options and other community supports because we're doing this social determinants of health screening, and we're figuring out where their needs are unmet and how we can meet them. And this was based off the CMS Accountable Communities Health-Related Social Needs Assessment, and it's linked in the PowerPoint that you'll get after this presentation. The lessons we learned was that our program would benefit from an additional hospital to home liaison. We only have one assigned to each hospital site, so that's kind of hard when someone's out on vacation, sick, things happen, kids get sick. So it would really be nice to have 2 staff at each, and then we could bounce ideas off of each other as well. But we've only been funded for 1, so we're just grateful that we have that at this point. The other thing is that patients who are not eligible for mass health at time of discharge continue to struggle because there's limited access to services via their care plans. And patients who refuse support are oftentimes readmitted and seen multiple times by the hospital to home liaison. So we're trying to figure out a way to encourage them to buy into the program. Other than our enthusiasm, I don't know what other way we can. We keep telling them, please connect with us. We want you to be connected so that you don't come back here again. Or if you come back, the hospital staff and we can support you in the community. So that's our main thing. Our goal is to continue to support patients at discharge, to work to ensure that staff at the hospital feel supported, and to enroll all eligible patients in our program to ensure that we're addressing social determination of health concerns and meeting all needs. And we're so excited about the future ahead. On June 6th, the Healy-Driscoll administration awarded an additional $1.1 million in grants so that more patients could be able to recover and receive care in their home, per Governor Maura Healey. So we have new partnerships on the horizon. This month, we started our partnerships between AgeSpan, Greater Lynn Senior Services, and MGH Salem Hospital, and Mystic Valley, Minuteman, and Winchester Hospital. And I hope I'll be invited back by Adam to tell you more about those when we have data on them and when we can tell you how successful those are. I'm so happy. We love working with these hospital programs. And now I'm going to pass it over to Betsy Crimmins, and she's going to do our ASAP overview. Thank you so much, Betsy.
Thank you, Lisa. I just want to say it's such a treat to listen to someone talk about something with such expertise and passion. So thank you so much. As much as, you know, what Lisa talked about is really wonderful, our big concern is that this was a 2-year grant program through the Executive Office of Health and Human Services. And for many of our programs, the grant money runs out in March. So we thought it would be best to do this presentation now in the fall as we are brainstorming about how to keep all these wonderful programs, not just going in their current locations, but to expand. Like every hospital across the state should have at least 1, if not 2, liaisons. So the real key, I think, to all of this is that the ASAP staff person embedded at the hospital is literally a bridge back to a bunch of services at an ASAP. And I felt the need to put in this slide because a lot of people have absolutely no idea what an ASAP is. I think it's on some levels the best kept secret in Massachusetts, but we cover every single town and city in the state and provide a whole bunch of services, which Lisa, if you can move to the next slide. These are our core services. These are very tiny. I apologize. But you'll be able to look at it when you get the slides. So in essence, every ASAP, and there's 24 of them across the state, provide these essential services. So when Lisa's talking about going into the home, doing a SNAP application, bringing in services, all of these services, once somebody's brought into the ASAP, are available. And for each ASAP, which is an independent, locally, a local nonprofit organization, all of which has been in their communities for approximately 50 years. These are just the core services. There's other services and other really innovative programs that each ASAP provides as well. And we wanted to leave some time for questions. So I think right now we should look at the questions in the chat.
Thank you both so much for this presentation today. It was excellent. The energy is amazing. We've got 92 people still remain on our webinar here today. So just thank you both so much. This is really awesome. And I think looking at the list of core services is really a critical piece as well. And I know that, Betsy, I think at one point you had sent around the agency access finder from your new website. And I'm just going to pop that into the chat as well so that folks, if they need to find their access to their services, I just popped that in the chat. So thank you both so much. This has been excellent. Couple of questions, and we can go a little bit over time with the questions that are coming in through the chat. So first, Deborah Gregson asked, I'd love to hear more about how in-hospital patients are being referred to adult day health, including how much time is saved from adult day health referral to adult day health admission.
So we, as we know how adult day health works, right? You need to have a tuberculosis screening. You need to have an intake, a prior authorization if you're on Mass Health. But what we're doing is we're trying to start the assessment literally on the date of discharge from the hospital. So get my nurse to go out to the community that day, do the clinical assessment for adult day health, send it over to the adult day health, get the family connected to the adult day health, have the medical paperwork all signed out. And then, it's not meaning that the person's leaving the hospital and going to adult day health the next day, but it's just meaning that we're expediting the service. So they're not waiting for an intake assessment. Then they're waiting another week for a nurse to go out. We're prioritizing the case and saying we got to get this person to adult day health. How can the adult day health work with us to make this, streamlined? If the person's not on Mass Health, then getting out there, to assess them for the ECOP, Enhanced Community Options Program, so that we can pay for more services, including 2 days of adult day health, or have a caregiver support referral to pay for an additional day of adult day health. So we're just accessing all those resources. So I wish it would be like I could get them to adult day health the date of, 2 days after they came home from the hospital, but it's definitely taking like 1 to 2 weeks off of the program.
Awesome. Thank you.
Thank you.
The next question that's coming in from Dr. No asks, these programs are very valuable for patients and providers. How are you doing a financial analysis on the cost of the program and the return on investment from presumed future improved health outcomes?
Well, we are collecting data. If anyone wants to help us figure out how to do that, please get in touch with me. It's always a struggle to figure out how to value something you've prevented. So if somebody is able to go home as opposed to either staying in the hospital longer, going into a nursing home for X number of days or weeks, what's that value? What's the return on the investment that the hospital home liaison put in to make that transition back home as opposed to additional days of institutionalization? So the grant program itself had certain data points that are being collected. The hospitals are collecting some. Very much, we have lots of different sort of ways to input information, most of which are not uniform, as Lisa mentioned before. There's Tiger text in some places, there's Excel spreadsheets in others. That's sort of par for the course with nonprofits. So we are looking to sort of put together what a true ROI is, and it is difficult.
I was just looking at the questions just like quickly because I know we don't have a lot of time, but I saw that I apologize. I should have had a slide about our collaboration with hospice providers and visiting nurses, because absolutely we're collaborating with them in the community. I talked so long that I could have talked for about 12 hours about this, so I just cut it down to what I could do. But we definitely are collaborating with them. We're following up with them. When we see things in the home and vice versa, they're collaborating with us. And then I read from Rebecca that it looks like you've heard that when patients receive hospital to home, they're not able to use personal care attendants. That is not the case with our hospital to home program. Though that may be the case with the program, like out of a hospital that's doing like a hospital program where they're discharging people directly, where they're giving like IVs, like a Mass General program hospital. Our program, we can provide services. The VNA can provide services. You can have your PCA as long as there's not a duplication of services through Mass Health. So like I can't send in my companion hours while your PCA is there, or do PCA care tasks that your provider is being paid to do by Mass Health, but we can provide respite, we can supplement, we can, find a way to adapt a care plan. So I just wanted to clarify that. And then I'm trying to see.
How about
Did I miss anything? Okay, I'm sorry.
no, that came in was, if you already have a relationship with a Mass Health ACO, does the hospital have an additional liaison through that program for the non-Mass Health patients, and how does that work?
So our hospital works with patients who are, our program works with patients who are Mass Health and non-Mass Health. So we're working with any patient that's leaving the hospital. They do not have to be on Mass Health. But as we know, patients who are on Mass Health, we can provide more services for. So if someone's connected to an ACO, like we can see that through, EVS, and then we reach out to the ACO to let them know that we've, that there's for a warm transfer with whoever's assigned to their program.
I just want to say that is one huge key to this program. It's insurance agnostic. It doesn't matter who's covering you or if you have no coverage at all.
Right.
Yeah. So another question that came in, Tara asks, how does the hospital home program differ from the ASAP's core contracting function to screen for nursing home services and determine that there's no suitable community placement or supports? Is this the cost of embedding an ASAP case manager in hospitals? You're just trying to understand kind of how this works from a sustainability perspective.
Right. So we are, we're screening patients who are on Mass Health for hospitals who are like acute inpatient hospital screenings, right? We're contracted as ASAPs. If someone needs to go to the nursing facility from an inpatient level of care, but that's only a small pool of patients that we're seeing, right? And we're really doing that based off a paper review of an MDS. Having a hospital to home liaison embedded in the hospital, seeing the patients on the floor, and then determining, some people we would never even have a contact with without knowing them through this program. I feel like it's definitely a difference from what we're typically doing. We would only be screening those patients, and then our ASAP nurses would see them at the nursing facility within 30 days to reassess and see if they were appropriate for a supportive, care plan that would discharge them to the community. We're catching them like even before they go in this program and then determining. So that's the kind of difference. Betsy, I don't know if you have anything else that I am missing.
No, I mean, again, being embedded, being part of that care team, seeing somebody from moment of admittance all the way through is really the key. And then the bridge back, you couldn't create this program at the hospital, because the true key is that when Lisa's on site at Cambridge Health Alliance Hospital, she knows exactly who to call back in her office. And she knows what Mystic Valley does and what they don't do, but she also knows what Everett Council on Aging might provide, or another local community-based organization. That's the key, I really think, to the entire ASAP system is those local contacts. And as you've seen from the slide, I showed the huge array of services that ASAPs provide.
Mm-hmm.
So Jennifer also asked, do you interact with PACE in any particular ways?
Yep. So if a consumer's enrolled in PACE, like we will contact the PACE provider if we need to, and let them know that the person, needs to go home, because we could provide meals for someone that's in PACE. Other than that, we're really not anything else that we provide is not available, and PACE needs to provide it. But if someone has a nutritional need and the hospital staff has determined that, we could supplement with meals. And then sometimes people decide that they need to, they need like 24-hour care services. They might disenroll from PACE and then go into our Community Choices program through the Frail Elder Waiver, and we would, help support a warm transition with their care team as well, and figure out who their doctors would be. So yeah, we communicate with all providers. We're on the phones here.
So while we're waiting for the next questions to come in, please feel free to go ahead and put your contact information in the chat, both of you.
Yes.
I've had some folks reach out while we've been sitting here saying,
Sure.
can I get their contact information? Because I think they'd like to have them come speak at another presentation.
Thank you.
And while you're doing that, I'm actually entering in the press releases from both the administration in 2023 and 2024 announcing the awarding of the various partnerships. So I know some folks on the call had asked specifically about which hospitals were actually involved in the program. So it gives folks a sense of which hospitals are participating in it right now, because I know folks are very, very, very interested in it. So Betsy put her in, and thank you for both for putting your emails in there. And we can get those. Do you mind if I put them into the chat directly?
Sure. I'm sorry. I think I might have just direct messaged them by mistake. I'm sorry, Adam.
No, you're okay. You're okay. I'll put them right now.
And then I saw, do you have an eligibility criteria, or is it limited to specific diagnosis? There's no eligibility criteria and there's no specific diagnosis. So we will literally take any referral for anyone in the hospital. Like we take 45-year-old people in the hospital. We take 60-year-old people in the hospital, 80, 100. And it doesn't matter what their diagnosis is. They're in the hospital. They want to return to the community. The issue is that if they're 30 or 45, we will not be able to provide them services unless someone's like duly eligible for Medicare and Mass Health, and they could go into a one-care program. So what we could do is say, okay, looks like you're struggling. Let's see if we can get you over to Boston Center for Independent Living and see if they can help you, get some services in place. Or let's see if we can go to Mass Rehab now, Mass Ability. Let's see who we can apply to. Or, you're on Mass Health, Common Health. Maybe you need to go to a nursing home for about 30 to 45 days. Let's get you in our CTLP program and figure out we can apply for one of those waivers. There's so many great waivers in our state. ABI waivers, MFP waivers. I could do a whole program on waivers all day if you needed me to do that, Adam. I love waivers. So we could apply for a waiver when you're in the nursing facility, right? And then we can get you in the MFP demo and we can get you money to go home. So there's so many different programs that we have access to through an ASAP. And so we're going to, take your case. We might not be able to provide you services in the community, but we're going to figure out a way that we can help you.
So Jennifer says the program waivers would be great. So it's definitely something we can think about for the future.
Great.
All right. I don't think there's any other questions. One other question that came in, hold on one second. There's
not a question for the webinar, but if we don't know eligibility criteria, how do you know you're preventing a nursing facility admission? So we gather all of the criteria on our patients. Like we have, we're all gathering their admitting diagnosis, their length of stay, whether they're going to transition to the community. And then we have we're tracking everything in Excel. This is the only way we can do it, but we do have drop downs of why they weren't able to go home. So we have not enough informal support, not enough formal support, change in medical status. So we are tracking that. But if we had eligibility criteria, then we felt like it would really limit a lot of the referrals that we get, because we get so many referrals for someone might have just come in for a social emotional issue, or someone might be, having a psychiatric issue. If we just limited it to hypertension, diabetes, and congestive or chronic heart failure, we felt like we were really limiting it. So, when we did this round back in 2012, when I used to be the transition facilitator doing this work at Mystic Valley Elder Services, we could only admit people with certain chronic diseases, and we missed a ton of people, so we just really wanted to open the doors to everyone that would benefit from our services. But thank God I'm not in charge of collecting data. I'm just the nurse and the social worker. That's not a strong point. So we get other people that do that, right, Betsy? She'll tell you.
All right. So go ahead, Betsy.
Another really interesting question just came in that in your case study, absent this program, how would that gentleman's discharge been handled? Lisa, I think you'd be able to answer that, but
yeah,
I can tell you he would.
Betsy can tell you.
He'd still be in his car without housing applications, without food. He'd probably have been admitted back into the hospital several times, and he wouldn't have somebody like Lisa and her staff checking on him, making sure he's going to get to his next best place, which is ideally a safe roof over his head so he can, get back to work or get on disability benefits, economic security, housing security, health security. Those are all ASAP staples. That's what we are subject matter experts in. And without this program, he never would have gotten over to the ASAPs to provide that whole array of services.
All right, last question, and it's a good one that just came in. Ashwini asks, does the clinical team then decide whom to refer to the hospital to home program? Do you reach out to the clinical team with a list of eligible patients?
So we have met with the hospital staff, and we frequently regroup and check in with them, and we just let them know, if there's a person that are ideally patients who are older adults, we're the ones we want, who are not connected to services, but any patient that they're struggling on a discharge with, we want to talk it out and figure out a way to work. So we're really, going through the daily Epic census, and then at Melrose Wakefield and the Saints Memorial campuses, we're kind of reaching out and saying, if this patient's not referred, I saw this patient, they're 74, they have nothing to do with Mystic Valley Elder Services. We're going to go up and see them. So we're looking at that. At CHA, we're definitely taking all their referrals in the in basket, and they're just looking like, okay, this person needs additional supports on the way home. I need to figure out what the next steps are. They've never been connected to an ASAP. Like, I'm going to refer them, but they may have someone who, doesn't meet the qualifications to be part of an ASAP, but they're still going to refer and figure out, because we kind of are the community access person to help them navigate the system to save the social workers and nursing care management staff time, so that they don't have to look for these resources and get the Boston Center for Independent Living information to this patient. Like, we're taking over and figuring out how we can support them.
Awesome. Thank you. I think that's a
Thank
great
you so
point to
much.
stop on. Again, just really, we're coming up on time, but I want to thank both Betsy and Lisa today just for an outstanding presentation. And we're really looking forward to working with you and continuing our work with you on this, because we know it's been such a critical lifeline for so many of our patients. So thank you.
Thank you so
much. And thank everybody, please, for joining us today on our webinar. You can scan the QR code that you see on your screen right now to see all of our educational programming. We have several events coming up in the fall and this winter, including our Healthcare Leadership Wellbeing Summit on November 15th, our Women's Conference that's coming up on December 5th, and our annual meeting that's coming up in January. So we hope that you all have the opportunity to come join us soon. Thank you all so much for joining us today. Really appreciate it. And we'll be back in touch with you all very soon and see you on a future webinar. Thanks a lot.
Thank you.
Thank you.